Tumor lysis is basically a clinico-metabolic syndrome. So what is tumor lysis? To keep it very simple, it's a tumor which is lysing. So the cells are breaking apart and releasing whatever is there in the cell into the bloodstream. So this is the first and most important thing is the definition of tumor lysis. Coming to the causes of tumor lysis are those cancers which divide rapidly. So you would not see tumor lysis in slowly growing tumors. You would see it in quickly growing tumors, those tumors which have a very fast doubling time. For example, you would see it in a Burkitt's lymphoma. You would see it in non-Hodgkin's lymphoma. You would see it in acute lymphoblastic leukemia, acute myeloid leukemia, and sometimes in certain other solid tumors. So those tumors which grow very fast, mostly hematological malignancies, which have a fast doubling rate, number one. Number two, you would also see tumor lysis in those patients whom you have recently treated, be it with chemo, be it with radiation, or be it with steroids. Sometimes we also do see spontaneous tumor lysis in those.
Symptoms.
So basically it is lysis of the tumor cells. So what all which is there within the tumor comes out. So as a rule of thumb, what we should understand is there are 4 or 5 things which happen. One is release of potassium into the bloodstream, release of uric acid into the bloodstream, release of phosphate into the bloodstream. So these are the 3 most important things. What happens is the phosphate sequesters the calcium and you have a low calcium. So you have a high uric acid, high potassium, high phosphate, but a low calcium. And also the calcium phosphate can go and deposit in the tubules of the kidney. The uric acid can go and damage the kidney tubules, leading to acute kidney injury or raised creatinine. So basically you are having a fastly growing tumor which is lysing, releasing all its cellular contents into the bloodstream, which causes these electrolyte imbalance.
Dealt with.
So from a nursing point of view, what we should understand is when a patient comes to the clinic, how is a nurse going to identify or how is a doctor going to identify that somebody has got tumor lysis? So you are going to identify tumor lysis in, as we discussed, those patients who have a high risk for tumor lysis, like the cancers we discussed, number one, who have recently received therapy, number two, those patients who have bulky disease, large volume of disease on their scans. And these are what are the symptoms they're going to present with. They can come with confusion, they can come with delirium, they can come with seizures, they can come in a comatose condition, they can come with polydipsia, they can come with constipation, abdominal pain, arrhythmias. So these are all manifestations of your electrolyte imbalances. So high potassium can lead to cardiac arrest or they can come with arrhythmias. Uric acid elevation can lead to acute kidney injury. So they can come with the low urine output or they can come with fluid overload. Again, hypocalcemia, they can come with tetany, they can come with features of abdominal pain, they can come with seizures, they can come with coma, altered mental status. So anybody who has recently received treatment or chemotherapy for hematological malignancies, who comes in an altered state or any of these symptoms, we are going to start thinking on the lines of tumor lysis. So what are we going to do at the first instance? As usual, as always, airway, breathing, and circulation. These are the 3 most important things when somebody comes to us in a sick state. You're going to identify their airway, you're going to secure their airway, you're going to look at the breathing pattern, maintain the circulation, secure an IV access line. If they already have a chemo port or a centrally accessible device, great, well and good. Otherwise, you're going to secure an IV line. You're going to look at their temperature. You're going to see they're not hypoxic, they're not hypotensive. You're going to get a baseline ECG done to look for arrhythmias or QT interval, because hypocalcemia can lead to prolonged QT interval. That can give you a clue much before you get your calcium. You're going to look at tall T waves on the ECG. That's an indication of hyperkalemia. That comes much before you get your ABG done. Get your ABG done. Send for all these labs. And once you are ready with all these, you can initiate, even before you're ready with.
To add on this topic?
Yeah. So most important is once you identify it's a tumor lysis, how are you going to treat the patient? So the aim is to correct the electrolyte imbalance and to correct it as soon as you can. Suppose, so you would, tumor lysis is divided into clinical and laboratory. Clinical is what we discussed with all the clinical parameters. Laboratory tumor lysis is a uric acid which is more than 8, a potassium which is more than 6, a phosphate which is more than 6, 6.5, a creatinine which is in the upper limit of normal, and a calcium which is less than 7. So the most important thing in tumor lysis is identifying the patient, as we said, airway, breathing, circulation, aggressive hydration, uh, preventing fluid overload is an important thing, especially in the elderly and those with comorbidities. Rapid correction of potassium is extremely important, and rapid correction of potassium is done with either an insulin glucose drip or an infusion, or salbutamol nebulization, and stabilizing the cardiac muscle membrane by giving calcium gluconate. Uric acid is lowered by allopurinol, but the problem with allopurinol is it doesn't act on the already formed uric acid. So somebody who's having a high uric acid and you also want to get away with the formed uric acid, you are going to give rasburicase, which breaks down that uric acid to allantoin and helps it excrete it. So we are going to take care of high uric acid in the form of allopurinol and rasburicase, which is xanthine oxidase inhibitor, allopurinol being one. Potassium is most important. Aggressive hydration, checking for the fluid overload, that should be fine. And then those patients who are refractory to these measures, who are in a clinically very, very sick condition, creatinine is very high, potassium is extremely high, those are the patients whom we would take up, or who have anuria, those are the patients whom we would take up for an emergency dialysis for rapid lowering of potassium and creatinine, so that